Welcome to Somatic Symptom and Related Disorders. First, I want to talk about some of the common features that we will see across the somatic symptom and related disorders. One, there's a prominence of somatic symptoms that are associated with significant distress or impairment. Remember, somatic comes from the word soma, and soma refers to body. So bodily symptoms, body-related symptoms that are associated with significant distress or impairment. They have excessive preoccupation with health or appearance. This preoccupation is intense and it is persistent to the point that it dominates nearly every domain of their life. And it can be so severe that it may warrant consideration as even a delusional disorder diagnosis. They may exaggerate the severity of their actual symptoms, and people often, but not always, describe the symptoms in very dramatic ways. Often these individuals are encountered in primary care and in medical settings rather than mental health centers because they honestly believe that the concern is rooted in their bodies. So they seek medical care, not psychiatric care. And as we talk about them, you'll see that there are many features that are similar to what we talk about with the anxiety disorders. And they're often comorbid with a variety of medical disorders, anxiety, mood, and personality disorders. Our first category of diagnoses within this group is somatic symptom disorder. Here we see that there is at least one bodily symptom that is distressing or resulting in significant disruptive in their daily life. And they have excessive thoughts, beliefs, feelings, behaviors that are related to that symptom or associated health concerns as manifested by at least one of these factors. One, a disproportionate and persistent thoughts about the seriousness of one's symptoms, persistently high level of anxieties about their health or their symptom, an excessive time and energy that's devoted to the symptoms or the health concerns. Individuals with somatic symptom disorder may actually change what that key symptom is. So although their somatic symptom may not actually be constant, being symptomatic with having some somatic symptom is persistent for at least 6 months. And similar to other conditions, we then would add some specifiers. In the past, we had pain disorder, and now pain disorder has been usurped under somatic symptom disorder, where we give the specifier of with predominant pain. And then we would also give some indication of severity. So one, we would list persistent, and persistent refers to there being severe symptoms, marked impairment, and a long duration. So at this point, they've gone over that 6-month period. And severity is rated by those criterion B symptoms from our last slide. It would be deemed mild if they only have one of those symptoms, moderate if they have 2 of those symptoms, and severe if they have 2 of those symptoms and there are multiple complaints, or one symptom that is very, very, very severe. So just to remind you, this would be disproportionate and persistent thoughts about the seriousness of the symptom, high anxiety about their health or the symptom, and excessive time and energy devoted to the symptoms or the health concerns. So whether they have 1 or 2 of those, or if there are multiple complaints and very severe complaints, would be what we would use to add a specifier of mild, moderate, or severe. Sometimes it can be difficult for individuals to have empathy for these individuals because they will have these reactions to the somatic symptom despite there being no medical evidence that they have any problem at all, and there is nothing that would support their experience. Despite the fact that we can't medically prove that there's a symptom or there's a cause for it, even when we've been able to demonstrate that there is no medical cause and there is no, the symptom isn't there, we have to remember that the suffering they are experiencing is authentic. their fear, their concern about it is true and authentic. And sometimes what's happening is that they're having normal bodily sensations or normal bodily discomfort that they're misinterpreting as signs of an illness, or they're appraising them as being incredibly harmful and threatening. They will have high levels of anxiety about the illness. They'll think the worst about their health. And when severe, individuals can actually become chronically ill or disabled. Something called invalidism, the state of being an invalid, especially by reason of ill health. So even though we can't medically justify that they're having the suffering at all, it is authentic and genuine for them and can even lead to them being unable to function. Somatic symptom disorder has now been created with DSM-5 and includes past disorders. Formerly, we could diagnose someone with somatization disorder, pain disorder, or hypochondriasis. But now, all of those cases are included in somatic symptom disorder. In fact, 75% of the cases with somatic symptom disorder would have been people that previously had one of these diagnoses. So whereas we used to say somebody was a hypochondriac, we can't say that anymore because it doesn't exist. It's not a thing. Somatic symptom disorder is also associated with depressive disorders, and this combination can be particularly dangerous because it's associated with an increased risk for suicide. Figuring out the prevalence of somatic symptom disorder is tricky, partially because this is a new disorder, and because there's now a much wider range of people that would have this diagnosis, meaning that in the past we had something called somatization disorder, and it required a very high standard, and less than 1% of those people qualified. We also had an undifferentiated somatoform disorder, and up to 19% of people, 19% of the people could qualify for that. The expected prevalence rate for the new disorder is between 2 and maybe 7% for adults, with the expectation that women will have a higher report of somatic symptom than men. But again, all of this is conjecture because we're looking at the data from the past disorders that have now all been grouped together and hypothesizing about what that might look like. Our next disorder is illness anxiety disorder. Here, individuals have a preoccupation with having or acquiring a serious disease. Interestingly, though, they do not often have any somatic symptoms, and if they do, they're very, very mild. And despite that, they're constantly concerned that they have acquired or will acquire this serious disease. And this is tricky because there are individuals who may have a reason to be afraid that they're going to acquire disease. Perhaps there's a family history, or perhaps they know that they have some risk factors. And when that's the case, we still want to look at if their preoccupation and response is excessive. Individuals with this condition have a high level of anxiety about their health, and they are easily alarmed about personal health status. And then we see that they often will engage in excessive health-related behaviors or exhibit maladaptive avoidance. For example, they might repeatedly check their body for illness, or they may avoid doctors and appointments altogether because they're afraid of finding out about illness. Again, we're looking for this illness preoccupation lasting for at least 6 months, even if the particular illness that they're afraid of has changed. For example, maybe they were afraid of cancer and now it's switched to diabetes. Remember, I noted that individuals could engage in pathological avoidance or kind of constant checking behaviors. Well, we want to have a specifier that gives a better picture of what these individuals are doing. So we specify if they are care-seeking or care-avoidant. The care-avoidant would be that group that avoids going to doctors or seeking medical care to a point where it's pathological. And the care-seeking might be that group that's constantly going to medical appointments and finding out and asking for tests to find out if there's something wrong. This is a new disorder, so we do not have an exact prevalence rate for it. Based on the past experience of hypochondriasis, we anticipate that in a medical population, this could be 3 to 8% of the population, and that it will likely be equal across men and women. And the progression, we anticipate that this will be a chronic condition with many relapses that worsens with age, probably began early to middle adulthood, and then continues to worsen. Thankfully, it's very, very rare among children, but we do see it frequently as individuals become older, and when they're elderly, the focus may start to switch to memory loss. This condition in particular, over 2/3 have another major psychological diagnosis. Conversion disorder is a condition that has been portrayed on popular culture and in movies several times. If you've ever heard of hysterical blindness, hysterical paralysis, they're really talking about conversion disorder. Here we see that there's at least one symptom of a motor or sensory deficit that would suggest that the individual has a neurological condition or a similar medical condition. Again, this will often be blindness, paralysis, muteness. It could be weakness in a part of the body or having a tremor, a shake. And in the past, we would often see that individuals would have some medical testing, but once someone decided that there was no medical evidence for it, they were assumed to have conversion disorder. And we've now increased the standard of care, where rather than just we've done some tests and we don't think there is anything there, now we have a higher standard where medical evidence has to demonstrate that the symptoms are incompatible with there being a neurological disease. And this is incredibly important. So not merely that there's an absence of evidence that it exists or that the symptom seems too bizarre. We have to show that it is impossible for it to go along with neurological conditions. One way that they might do this, if the person has tremors as an example, is with the tremor entrainment test. This would be an individual who has a tremor and they're trying to figure out whether or not the tremor is related to something neurological or if it is psychological, if it's a conversion disorder. And they may ask the person to do something with the other hand, the hand that does not have a tremor, and ask them to either concentrate or do a particular activity. And what they find is, if it's conversion disorder, when they're highly concentrating or when they're engaging in that activity, the hand with the tremor may mimic the activity or may stop temporarily. In essence, what's happening is the concentration they have to put in the activity is interfering with them engaging in the tremor behavior. This is incompatible with neurological disease. If it were a neurological condition, their tremor would remain consistent despite the fact that they were concentrating on another task. Conversion disorder is often associated with dissociative symptoms, especially at the start of an attack, meaning someone may become dissociative and then move into having the conversion symptoms show up right at the beginning of something happening. Because the onset of the symptom is often associated with the onset of a stressor, we assume that there are psychological factors involved. And it's important to emphasize that individuals are not intentionally faking these symptoms, meaning the fact that they're concentrating and the tremor stops, that implies that it's intentional, but we shouldn't think about it that way. It's happening for a psychological reason. They're not consciously and intentionally trying to fake the tremor. When we are looking at this diagnosis, we would add if there is evidence of labile indifference, where they demonstrate a lack of concern about the symptoms. So you might imagine if I'm experiencing temporary paralysis, I would likely be very distraught about that. But some individuals will have these very concerning symptoms and they don't seem to care. They don't talk about it as if it's a concern. Now, this is common for this disorder, but it is not required for the disorder. We'd also want to differentiate between conversion disorder and some kind of secondary gain. And again, secondary gain refers to there being unconscious motivations for someone to experience the symptom or to report the symptom. And this can be common in many of these disorders as well as many other disorders. Some examples might be that, if you're having this symptom, well, you can't go to work, you get time off, or you're getting lots of sympathy from other people. People are coming by and helping. The secondary gain could create an unconscious motivation to continue or exacerbate a symptom. This is different from malingering, where the individual is deliberately exaggerating their symptom for personal gain. So we want to figure out, are we seeing malingering, secondary gain, or label indifference? And we would also expect for prognosis that there's going to be sudden starts, then sudden stops, and that this is going to recur frequently throughout their lifetime. Thankfully, conversion disorder is very, very rare. Only 2 to up to 5 cases occur out of every 100,000 people. It's higher when you look at outpatient referral clinics, 1 to 3%. And of course, because they're being screened, they often appear to have a neurological condition. Neurology clinical referrals have much higher cases. It can be up to 5% of their cases are actually conversion disorder. Women are 2 to 3 times more likely to have conversion disorder than men. And the age of onset can be any time in the life course, but it's more common in adolescence and shortly thereafter. When you see this in children, there's a better prognosis than when you see this for individuals who develop it later in life. Typically, symptoms will show up quickly and then end very quickly, and when they're there, they don't last for very long, but they can be very impairing while they are there. But individuals will often have relapses and reoccurrences throughout their lifetime. In fact, if you were to look at just a 1-year time frame, you'll see that anywhere from 20 to 25% of them will have another episode within that same year. And interestingly, there seem to be differences in what we can expect for the prognosis. Individuals who have blindness or paralysis tend to have a better prognosis than those that have tremor or seizures as their primary symptom. Our next disorder has also been demonstrated in popular culture and on various movies. It's called Factitious Disorder, but you may have heard of it referred to as Munchausen's. When we are diagnosing factitious disorder, we would indicate whether it was imposed on the self or imposed on another, or by proxy. This basically means, am I engaging in this and doing this to myself, or am I doing it to someone else, like a patient or a child, somebody who I have control over and I can do things to? The first criterion is falsifying physical or psychological signs or symptoms, or causing injury or disease with the deliberate intention of deceiving others. This may be doing things to cause vomiting or cause illness, doing things to injure their body, but this is done because they're trying to trick others and they're conjuring symptoms, they're not genuine. And then the individual will present either themselves if it's imposed on self, or the other person if it's imposed on other or by proxy, present to others as being ill, injured, or impaired. And interestingly, they're engaging in this deception even though it's not clear what kind of positive reward they might be getting. So we will often think of this, very often they're either making themselves or somebody that they love very, very ill, or doing things that are very, very harmful, and can be really horrible. And we would think of these as typically not being gratifying at all, but still the individual continues to engage in this behavior. When I also want to make another clarification, when we are talking about it being imposed on another, the perpetrator is the one that is given the diagnosis. So if a parent is diagnosed with factitious disorder imposed on another, this might be that they were making their child sick, or making it appear that their child was injured.